The one thing that Musk commented on was, and you'll love this, was a repeat of the old Duisburg HIV does not cause AIDS misinformation around the old drug AZT being responsible for most of the deaths related to HIV.
Wait a minute, Elon Musk brought that up?
Back in November,
back then or recently?
November, Eric. He brought it up in November. Welcome to the Global Health Diplomats, brought to you by A Shot in the Arm podcast, a project of the Global Listening Project with the support of the John Martin Foundation. I'm Ben Plumley, and I'm joined by my partner in crime, Professor Eric Goosby, Ambassador Eric Goosby. Eric, welcome back.
Thank you, Ben. Glad to be back. Happy New Year to you.
Happy New Year. You sound a bit down, a bit pensive. I'm doing my utmost to be as upbeat as I can. But God, what a year 2025 is going to be.
It is. What's been really, I think, extraordinary about this moment of as the Trump administration positions itself to take over is the frenzy of anxiety rising kind of on all quarters because of the lack of clarity on exactly what are we doing, where are we going, and what will the future demand from us, wanting so much at stake to still stay on track. So many lives being dependent on the structures that these systems are supporting. And a domino effect is very easily introduced. And we're kind of waiting with bated breath to see how this is going to unfold. High stakes.
High stakes. And I mean, obviously, we're recording this on the Thursday before the second Trump administration is inaugurated. I think we're all expecting a rash of executive orders that are going to affect global health diplomacy. So you and I will be back after the inauguration to just reflect on what the first stages are going to be for us. I was doing a search prior to this call, this podcast, to see what Elon Musk has said about HIV. And also this reflection that Elon Musk, Peter Thiel, and others, you have this body of white South Africans who are now in the tech sector in Silicon Valley, but playing a very significant role in influencing the Trump agenda. So, I think it could go any way at all. But the one thing that Musk commented on was, and you'll love this, was a repeat of the old Duisburg HIV does not cause AIDS misinformation around the old drug AZT being responsible for most of the deaths related to HIV.
Wait a minute, Elon Musk brought that up?
Back in November,
back then or recently?
November, Eric. He brought it up in November.
Goodness. Well, my mouth drops because that has been, having been one of the co-PIs on the AZT investigation at San Francisco General with Paul Volberding, David French. There were a lot of people who participated in that original research, but it increased longevity by 18 months. And that was the big finding. And that's why we used it. It was so. What was the causal relationship of AZT? I remember when that came out back when it came out of Berkeley during kind of I guess it was the late 80s. I'm just trying to remember when it was, but we were at San Francisco General's AIDS clinic when it came out and refuted it, and he came over and gave a talk or two, but his talks were not really scientifically grounded in their totality, so we kind of faded in our relationship.
That was old Professor Duisburg, right?
That's right, yes.
Yeah,
so.
yeah. Well, and of course, I remember it from the UK side, and the whole gays against genocide activism in the UK, particularly London. And I think the concern was that high doses of AZT was a powerful drug, that these were in fact causing AIDS-related symptoms, not HIV. And then, of course, we had Tarbo and Becky in the early 2000s reiterating the denialist. So, and of course, even more recently, Trump's pick for Health and Human Services, Robert Kennedy Jr., has also reiterated some of those Duisburg concerns. So who knows? Who knows? But it's an interesting introduction to the future of HIV therapy post-2030, because the past is prologue. You and I wanted to do these series of podcasts because we were concerned about tackling perhaps a simplicity in public health thinking that HIV would end as a public health crisis after the golden date of 2030. And so we were looking at what the agenda needs to be for a long-term AIDS response in the coming decades. And obviously, the starting point for that is HIV research and development. And I guess one of the incentives that I had for wanting to do this episode was a comment you made in our introductory episode about the post-2030 agenda, sort of dangling out there this question that, well, do we have adequate tools for HIV prevention and treatment now? And should our focus not be further basic research, applied research and development, but a focus on delivery, and particularly looking at the diseases that people with HIV on long-term therapy are facing? And that came out at about the same time that an article or an opinion piece in the New England Journal of Medicine from Winnie Bienmina, head of UNAIDS, Linda Gale Becker from the Desmond Tutu Foundation, and Matt Kavanagh from the O'Neill Institute, suggesting that, in fact, we had the silver bullet, that perhaps the new long-acting lenacapavir injection, which promises, twice yearly injections, could be the solution to the AIDS epidemic. So that's how we got to this topic. And I guess the first question for you, Eric, is, as you look into your crystal ball, do you think this kind of basic and then applied biomedical research is still needed for HIV? Or do you think we've got what we need and let's just get on delivering it?
Well, that's a great question, Ben. I think we do have many of the elements of a strong preventative strategy that could target specific populations and specific regional areas and maximize your ability to minimize spread of the virus through that individual that's HIV positive, and secondarily through the community that they reside in and are socially networked in. We have the tools that can block transmission in progression in an individual and progression through population exposure in a social network system with both our antiretroviral drugs that are short-acting and the normal ones that we've used. The intermediate acting, the 2-month injection, gave us another arm of response to that picked up people who were poorly compliant with their daily required antiretroviral therapy, of whom there are many that fall into that category. The 2-month injection grabbed all of those, but there are still individuals who don't come back after 2 months. And the 6-month now preparation with lenacapavir coming forward now, as the research for that, looking at its use in actually treating active infection and not preventing it. So in an active infection, not in a person who you treat with a long-acting and it prevents infection, but documenting that this will be used effectively as a therapeutic intervention. There's no clinicians who think that won't be the case. That's, of course, how it's going to work. We need to prove it, and then the use of that drug will really broaden to capture all of that. With antiretroviral therapy and with short and longer acting antiretrovirals, I believe the armamentarium toolbox needed to really contain spread through populations is there. It's a now implementation challenge to get the knowledge and the drugs in the right people to prevent that spread. And that is really where the rubber meets the road on the need. It is an implementation need. It's an implementation science problem that can be easily engaged with by implementing the program that you've already agreed to. So I feel that we are there, and your question to me raises whether or not we should support further investment in investigating for the cure for HIV. My whole career has been so focused on the cure, it gets stuck in my throat, really, to not continue to do basic research that would delineate that. But I am also a practical clinician who sees resources going to one thing and not going to another. And that, unfortunately, continues to be the game we're in at the federal and multilateral international level. So we need to be very conservative about how we allow these resources to be distributed across many interventions that do the same thing. There are times when we need to bring in an intervention because it grabs a different population and secures them for spread or infection, and that freedom needs to reside in the clinical teams looking at the population and understanding how it does spread through that population and putting these interventions in a position to block spread. We know how it works. We're good at it. It now really is implementing what we know better.
So that makes sense to me from a pragmatic perspective. There's one thing I think about this that keeps me up at night, and that is that we've moved on from a medieval understanding of HIV to perhaps a sort of classical empiricist understanding, a Newtonian understanding, if you like, of HIV. But there are still a lot of things that we really don't understand. And of course, even with these long-acting injectables, which are still antiretrovirals, although they target the HIV replication in different phases, they aren't cures. And they certainly do play a prevention role, but we still have things that we don't understand, like reservoirs. And for the lay listener or viewer, I'm not talking about the need for water reservoirs in Los Angeles County just at the moment. What we're talking about are the the areas of our body that produce white blood cells. HIV is able to get itself entrenched. And while we've had a look at whether long-term HIV treatment has been able to completely eliminate HIV from the system, there are still these HIV sort of hiding away in our lymph nodes and other areas of our body that could just be primed once the antiretroviral is gone. So what if there's still a degree, say, of humility in us needing to understand more about the life cycle of HIV and making sure that we have ready up our sleeve a range of interventions, whether it's, strengthening our own antibody system, what they call broadly neutralizing antibodies, whether it's, even the use of gene editing to strengthen our immune cells in different ways. Is there still a value, do you think, in that kind of basic research to make sure that we're prepared?
I would say there's always a value in that, in enhancing, enriching our understanding of how and what the natural history is of an HIV infection. The reservoirs sequestering that you're referring to is real. We saw it in the 80s, in the late 80s. We saw that your CSF could have persistent HIV as you moved into dementia. With early HIV in the 80s, we did thousands of LPs and did protein analysis on the CSF fluid to see what it looked like from an immunologic response level. And that ongoing response in your CSF, in your spleen, in your lymph nodes, in your retroperitoneum, all of those lymph nodes that are sitting in the retroperitoneum are harboring little lakes, pools of HIV that's sitting there dormant, not dividing, not presenting itself to the immune system and waiting for an opportunity. The long-acting took care of that because it's there all the time, waiting for it to emerge and come out and die as soon as it gets into the bloodstream. And that ability really did give us control of spread through populations that looked like a vaccine. And that's what you're bringing up. So the type of pattern you see in an epidemic when you introduce a vaccine is what our antiretrovirals really started to look like because they were so effective. And the yield and prevention that reflects for the population is considerable. And you got to ask yourself, what's the delta we get by actually eradicating the virus in the body with X amount of more investment in research to figure out how to kill the reservoir when we've already got an effective strategy that kills the virus when it comes out of hiding every time, that patients tolerate well, don't even know they're on the drug, and only have to get it every 6 months. I mean, that sounds an awful lot like a cure. Now, I know it's not, and still have the desire to get there, just like with hepatitis. And what a world it would be if we were able to do that. So I would never say stop the basic research, natural history-wise, pathophysiology on HIV. That is still a justified area of inquiry because of the morbidity and mortality that virus still delivers on the planet.
So
But
two quick questions, Eric. You referred to CSF. Do you want to explain just what that is?
Yes, your brain and spinal cord are floating in cerebral spinal fluid that is a water crystalline structure that mirrors the electrolyte composition of your blood, but is crystal clear. Like you hold it up against water, you can't see the difference. But the virus for AIDS dementia would put certain types of proteins that were consistent with inflammation in the CSF. So early on, that was the only evidence we'd have that there was a process going on that was dementing patients. AIDS dementia was quite pronounced and aggressive in the early years. People don't even remember it now. But it filled our psychiatric units and eventually nursing homes with demented 30-year-olds who were unable to really show any signs of improvement with any kind of treatment. They were very, there was no recovery of those individuals once they had achieved the demented state. So it was a tragedy that I would like to prevent. All of the antiretrovirals stopped it from happening. We don't see it anymore because that doesn't occur anymore because it gets it in the periphery before it goes into the CSF and kills it. So
here's the second part to that, Eric.
Yeah.
Then the argument that we have, to all intents and purposes, a functional, in inverted commas, cure for people on sustained treatment requires them to continue on that treatment, whether it is daily, twice monthly, or 6 monthly, or even annual courses of antiretrovirals. And I guess that does bring us back to the real world in that we are going to have to be facing a question of ensuring that people on HIV therapy, and this is something we discussed in our previous episode, are able to stay on that for life. The moment you are not able to access that medication, and the long-actings take about, I suppose, 8 months or so to clear from the system, but that's precisely the point where HIV reappears. And so, to your point about the practicalities of delivery, all of this is predicated on making sure that we have the supply and distribution and funding mechanisms, which are not the sexy biotechnology research, but which are crucial to ensuring that we have a long-term management system for people with HIV.
For sure. I think we would all love the magic bullet solution for HIV. We've been waiting since 1981 for something like that. And the amount of energy, resources, and kind of careers that have gone toward that effort has been breathtaking globally. The United States has led that effort historically and continues to lead it now. And I think this is a kind of public health decision as to what the planet can burden of costs the planet can absorb by continuing to do active, expensive, ongoing research to get that cure versus allowing a more thorough, complete distribution of the drugs and strategies we already have identified that are effective to be deployed where they're needed. And I would say the having the ability to know that the freedom to move between those different modalities is ideally the clinical situation we want. I am on the board for the pursuit of the IAVI's board is looking at the HIV vaccine that has efficacy.
International AIDS Vaccine Initiative, yeah?
Yeah. And believe me, there hasn't been a day that this broadly active blocking antibody strategies have come up with both IAVI and with TB research for anti-tuberculous drugs. So all of those things are being pursued, but not by the core research motors of NIH and some of the European motors. And I think you're right to call it. Ideally, it would be great, but I think we need to take the resources and efficacy that we have demonstrated with strategies for prevention and treatment, maximize those now. That's still the challenge in front of us. But I would never say don't continue to search for a cure. But I do get the economy of scale and limited resource argument.
Could I ask you a bit about lenacapavir, this 6-monthly injectable? It is a capsid inhibitor. It's a new class of antiretroviral. And it has really captured the attention, the imagination of the public health world, the global health world, to the extent that, let's just make it as widely available for treatment and prevention right now. And we should then be in a situation where we are, if not in 2030, but shortly thereafter, looking at the end of AIDS as a public health crisis. But what are the things about lenacapavir that interest you?
I would say that the real excitement is in the ability for that drug, with its introduction, to put a 6-month time frame between injections, as knowing that for a population that you're introducing antiretrovirals to, that's a complete capture of that individual, unless they have an allergic reaction to the injection, which is rare, but that would be the kind of individual who'd be pulled out of that strategy and would have to then go on to oral medications. They would try the 2-month, but they then would go back to oral if that didn't work or still induced an allergic reaction. That's a relatively small group of people. It's mostly going to work for both treatment and for prevention. So I really can't get too excited about trying to identify that smaller percent that don't work. It's roll it out, make it available, and deal with everybody's reaction to the drug. But we have every reason with our initial studies to think that this is mostly a implementation challenge, and that's really how we should look at it.
Well, let's turn our attention to implementation challenges and the innovation post 2030 that's going to be needed for that. In prepping for this podcast, Eric, I was looking at the storage requirements for the vials of lenacapavir. And, at the back of my mind, I was thinking of the super charged freezing that was required for the COVID vaccines. But lenacapavir only needs to be stored between 20 degrees Celsius and around about 25 degrees Celsius, which opens up a very significant opportunity for distribution and storage. Although, of course, in many parts of the world, temperatures are way above 25 degrees Celsius, and that's only going to continue, of course. But in terms of the innovation that's needed from the back end, supply, distribution, what have we learned, and what do you think we should be hopeful for and pushing for in the next phase of the response?
Well, in terms of the cold chain, hot chain requirements of a preparation, delivery systems throughout Southeast Asia, Sub-Saharan Africa, and India are very familiar with vaccine requirements for just regular measles, mumps, rubella, diphtheria, pertussis, tetanus type vaccines, which go everywhere. But all the polio and I would say vaccination cold chains that are set up are years old and institutionally kind of ratified by institutions and systems. So I have no real concern that we can't figure that out. That will be one of the more easily engaged problems to solve. The cost is going to continue to be the rate limiting factor, and the ability to get countries, and that's the change that needs to occur. We need to acknowledge that the ability for a multilateral approach to depend solely on one bilateral's ability to mount a budget and put a program on ground has got to evolve and mature into a shared responsibility that puts the country at the center of the need and puts them at the center of the dialogue internally to get the feedback for how last year's budget decisions delivered a program that is giving you the outcomes you, population infected, need and want. And that ability is really what we need to put our efforts into and give resources to countries to mount more effective implementation efforts that puts program on ground and a surveillance system that allows them to know that they are continuing to do it.
Now, you see, that was a classic global health diplomat comment, Eric. You spoke up front about not relying on one bilateral donor. I wonder, who would you be referring to? Would that by any chance be the United States?
Yeah, I am. I mean, I am grateful that the United States could play the role, would like the United States to continue to play the role. But if the United States can't continue to play the same role, what role can it continue, number one? And number two, what role must the country move into? And we are going to help them understand the delta in that difference needed for them to really come up with new strategies, new investment strategies to close that difference. The other piece then is that we need to embrace civil society's indignation with their government's unwillingness to invest in their health. We need to somehow, without being inappropriate, bring that to the discussion in every country we're in, because the real truth of the matter is the countries, populations who are infected with these organisms have a obligation from their governments to respond to that need, and it's not being responded to. That dialogue has hardly started in most places and needs to begin in a robust way. The United States needs to include in its technical assistance support strategies for generating new types of investment like venture capital kinds of things. The Clinton administration, when President Clinton was president, had a whole strategy in Haiti where he did just that, went in and set up kind of shopping centers with schools, hospitals, clinics, and ambulance services that came out of a shopping center platform, if you can believe that, that were locally invested in and not federal, not funded by the Haitian government, but by outside resources. That kind of strategy is what we need to converge on this and put the ownership back in the population so lines of accountability can come back into play because they're not there now.
No, and I suppose there's a contradiction here, isn't there? Because on the one hand, we know that, and they've been very clear, the administration and the Republican held houses of Congress are keen to cut costs, are keen to cut investment, are keen, and we heard Senator Rubio talk about this in his confirmation hearing yesterday, about focusing development aid very specifically on areas that support direct U.S. interests. And the question will be, we cannot rely on the U.S. as the taxpayer of the U.S., their largesse, to continue paying for life-saving HIV treatment indeterminably for forever. There is going to have to be a tapering off and a tapering up from local governments, national governments, as well as other donors. Yes, Europe, we're looking at you. But the contradiction comes in relying on those governments to prioritize the treatment of those communities that are most at risk, whether it's the LGBT community, whether it is the sex worker community, drug-using communities. And you see perhaps a backward trend as it relates to rights-based approaches. And we saw it very visibly, of course, in Uganda. You and I have spoken extensively about this. But that backtracking and that persecution of those communities most at risk of HIV has, in a sense, been driven by other elements of civil society in the United States, particularly Christian nationalism. And I guess that forces, to my mind, the need of other donors to step up. But I got to confess, we're not seeing that the UK, for example, with its new government, is going to climb back to the commitment to provide 0.7 of its annual GDP to development aid. You get the sense that other Europeans with economic trouble, and again, we saw that the German economy declined in the last quarter of 2024. It actually decreased. And you've got other commitments, other responsibilities that donors have. How, from a global health diplomacy perspective, do we get other people to step up? And that's even before we get to talk about what local national governments have to do.
Mm-hmm. It's the question of the kind of millennium, I think, is how do you get and engage a government to invest in a aspect of one of the needs of its population that are evident and in the government's best interests to respond to keep their population healthy and workers healthy and economies going, et cetera, et cetera, et cetera. I think that, to me, the missing piece is culturally often not perceived as missing because it historically has never been there. And that is demand that is generated from the population who needs and depends on the services. Indeed, it is so discombobulated in the minds of many populations that they don't see healthcare as a need that they can advocate for to their government. And I think that takes and requires an educational learning curve, but in no uncertain terms, it's the central piece that people in a country hold their government accountable for, is to keep them safe. And one of the central elements of safety is health, and health is the foundation on which economic and educational advances are built. So to me, it's a vitally important need to acknowledge and generate a demand from an informed, educated population on how their health care can be improved, changed, and moved in a healthy direction by appropriate interventions that are already understood and available, and that their government is not making them available to them, is got to be a transgression we define for them and help them advocate to their government, not in a destructive way, but in a constructive way, to bring that understanding and willingness to the people to communicate to their government that this is an investment we need and want you to make. So I think that is something that our UN agencies and our multilateral agencies have always taken seriously, but our ability to respond to the needs of high-risk populations, so-called populations that are disproportionately impacted by these epidemics, need a special approach to identify them, enter them in care, test them so they are identified as needing antiretrovirals or not, and go down if they're negative in testing for HIV, are a prevention opportunity still that we need to put in our system. And if they're positive, we treat them with antiretrovirals. Those treatments go into long-acting as soon as they're available, which means as soon as we can pay for them. And that is still the rational approach to take for this. But the inability for people to benefit from the science we already know, Ben, is the tragedy that we need to continue to display and get the populations in country upset and aware of the fact that they don't have to suffer with a disease that we can diagnose and cure or stop progression in and treat. It's that kind of a thing. So, for me, it's just anger.
So, Eric, that is really interesting. And if I'm understanding you correctly, what you are describing is a move to a more advocacy and influence strategy that helps civil society in countries call on and persuade their governments to strengthen, to increase their funding and their overall commitments, not only to the HIV response, but to health more generally. And it brings to mind the example of the United States in Europe in the 1940s, 50s, and 60s, with Radio Free Europe offering an alternative to Soviet communism. So as much as a global health diplomacy strategy, it feels to me like a political call. Would you go as far as to describe it in those terms?
Yeah, thanks, Ben. You're correct in calling that, and yes, I would, because I don't know what else to call it. It's acknowledging that we are at a point where our current strategy still leaves too many people unmet in terms of responding to their needs, and not minor needs, but life-threatening needs. And are we mature enough as a society, or as multiple societies, to say we have failed at this strategy? The need continues to expand, unresponded to, and we are not going to continue to watch it and try to respond with an ineffective strategy, but let's reconvene a discussion, one country at a time, that speaks to those unmet needs, acknowledges that the current strategy has failed in the following areas, and that we as civil society want to work with our government in a way that is not accusatory, but collegially, because we understand we benefit from the outcome of this decision, to put in a delivery system that specifically responds to those needs as we define them together, and gives us an opportunity to define more people in our population who have extraordinary needs that are being ignored, not identified, not entered, not retained in care, because of a being marginalized or in a peripheral behavior that does not interface with the delivery system. Those are things we can figure out how to mitigate, but we haven't. And what I'm saying is, are we mature enough to say we have not done it correctly, but we still see the need and we want to convene a process in country to define how we re-engage with this? The re-engagement to focus on defining the need explicitly by population at risk, so we include them in the response and not allow them to be left out of the response. On the front end, identify how it distributes in the population by risk, and then build our system to identify, enter, capture, and retain over time those individuals. Strategies that have not found resources to pay for this have to be defined and engaged and implemented with a kind of government, civil society, private sector triumvirate created new to go at this differently. Again, admitting that we have failed and that it's unacceptable to watch the carnage continue, and we're smart enough to figure out how to mitigate this better. So I'm talking about a reboot of how we define not only the problem, but most importantly, how and who should be responding to that problem in a non-accusatory way, converge a coalition that is focused on finding the funding and implementing the program, so those aspects in our community and society that are not self-identifying entering are identified and entered. So to me, it's a way to deal with both of those needs.
And that should be appealing to non-US funders who are going to be called to step up more in the next phase of the AIDS response. I can see the Europeans, whether it's the members of the European Union, Norway, or the United Kingdom, finding that very interesting. And as long as we can move them quickly from navel-gazing and discussion to action and transfer of funding, that makes a lot of sense. I mean, Eric, it just really strikes me that we are, back to the future. It's really clear that the next phase of the AIDS response is going to require incredibly smart thinking, both around policy, funding, and political commitment. It feels that we're right back at the UN General Assembly special session of 2001. And obviously, the one of the big elephants in the room is what happens to development aid and to the HIV response globally from the Trump administration. And obviously, we'll come back and reflect on that, and as we learn more about what happens, and I guess we're both thinking that that's going to be something that's going to take, despite a few perhaps rich announcements early on, is going to be something that's going to take a while to unpick and understand. But what are you thinking in terms of our next episode? What should we focus on, do you think?
Well, I think understanding and embracing the idea that we have not adequately responded to the needs that we have already defined, and that still remains undone, and that we still hold that as a challenge for the global health community to meet. To do that, we need countries to be honest about what they have and have not responded to in defining explicitly what their real unmet need is. Once that's defined by population at risk, we can mold a response. Because the good news is we have figured out what responses are effective, safe, and which populations are or are not receptive to them. So it's not like we're turning to a toolbox that's empty. We've populated that toolbox over the last 25 years, really going back to the mid 80s. And let's take advantage of all that. Take the knowledge we know, let the people who need these services, need that knowledge, mined for the pearl that's going to turn them around as a patient, as a person, get access to it, connect the dots, and acknowledge that there will be struggles that will continue in countries who do not have the resources to mount the perfect continuum of care and services. But we're going to we have defined what that continuum of care and services is optimally. We've refined it by populations. This is what the last 30 years has done. And now we're on the precipice of long-acting antiretrovirals, which adds another dimension to this that only improves our chances to get closer to 100%. And I feel it needs a different conversation to identify and concentrate resources that don't normally move together, talk together, or work together. It's time to break that barrier, break that ceiling, and allow private, public, and government to put resources together on the same problem they're all focusing on, to measure it the same way with a surveillance system that tells all of us how we're doing and holds us accountable. But that core civil society challenge to government is the seed that we need to water and nurture.
And it strikes me, Eric, two things. The first is that as well as we look at the tapering down of US and potentially other G7 development aid supporters, we need to taper up the response of the individual, local and national governments. And that's precisely where the multilateral system needs to play a role in supporting them doing that. If anything, I think what you've set out is a call to action for the continued relevance of a joint UN program on AIDS, UNAIDS.
I was just going to say that the ability of the role of the multilateral is to continue to hold governments accountable, not from a civil society perspective, but to add the multilateral pressure, and in adding that multilateral presence, expanding the resources that you are trying to access with that need to be added in a different way than we have historically done it. And we don't need to do a demo. We just need to do it in a few countries to just show it, but not to show it to prove it. This is proving something that we don't need to prove again. We just need to implement up a complete continuum of care and services and work with those countries that have weak links in that continuum, and make it an ongoing effort that kind of never stops.
It's sort of like the it's like the global health interpretation of Nike's logo or Nike's catchphrase.
No, just do it. Yeah, I like
just
that.
do it.
Just do it. Yeah. I don't want to do another pilot or look at
No.
I mean, we've done that for 30 years, and it's time to hold our political colleagues accountable for delivering on what their populations need. And I'm ready to make that argument one country at a time.
And it speaks to, in the context of prevention, the choice agenda that African women activists have really led on and supported AVAC, another international NGO on. As you said, we have tools in the toolbox, and they're going to apply to different people at different times in different circumstances. We just have to do it, not look for an additional magic bullet that puts all of these to
time to do it. Yeah,
time to do it.
Time to do it.
Well, what a great way to end this episode.
Good.
I mean, I just don't even know how to describe it. 2025 is going to be, from a historical perspective, a fascinating year. And it's great to be able to be with you documenting things as they happen, even if it's a bit of a white knuckle ride for us in doing it.
Yes, no, Ben, it's a pleasure, and to work with you on these questions has formulated the questions better in my mind. So it's a wonderful tweak for me to hold myself accountable to, like, well, so what are you talking about exactly? I really feel that life is short, and that the mortality of all of us being something that is a real and curtain in the final match. I look at this as something that so many of us have put so much of our careers into that none of us are going to let this slip away now. And I feel that your convening of these discussions is very much helping that occur. But it's time to try to put a new paradigm in there and acknowledge that we know a lot, and we now need to ask ourselves, do we know how to put these programs to ground everywhere? And where we can't, can we continue to perseverate over it and converge resources so they too get across the finish line?
I completely agree, and right back at you, Eric. I'm learning so much from this dialogue. So yeah, until we meet again, and the next priority in the AIDS response. Well,
thanks, Ben.
That's it for this episode. Thank you very much to my co-host Eric Goosby. Thanks also to Eric Aspera, our director and producer from NewsDoc Media. Thanks to the John Martin Foundation for their continued support of this podcast. And finally, a big thanks to you. You can find us on the podcast platform of your choice. But if you're so inclined, please do go to our YouTube channel, A Shot in the Arm Podcast, subscribe and like. And we will be at you again shortly with the next episode in the long-term agenda for HIV post-2030. Thank you.